Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today is Dr. William Kantz. He is a surgical oncologist by trade and is the Chief Medical and Scientific Officer for the American Cancer Society. Welcome, Dr. Kantz.
Thanks, Dr. Wexner. Great to be here.
Well, it's a pleasure to have you with us. The American Cancer Society, the ACS, has been a tremendous partner to the other ACS, the American College of Surgeons, in particular through the Commission on Cancer. One of the most recent initiatives that was launched by the American Cancer Society and is now being solidly embraced and promoted by the COC is a return to screening. So if you wouldn't mind, I'd like you to start by explaining to us some of the adverse effects of the COVID-19 pandemic on cancer screening.
Sure. So COVID has created a perfect storm to really have a negative effect on cancer screening. First, a lot of the facilities were shut down, particularly earlier in the pandemic. Second, there's a fear of COVID, a fear to go into a healthcare facility that you might get COVID. And finally, there's a lot of financial toxicity from COVID. A lot of people have lost their insurance. A disproportionate number of underserved people have lost their insurance. So that has really combined to reduce screenings by probably about 22 million over about a 3-month period. And that's going to result in a lot of people who not only have undiagnosed cancers, but we believe there will be excess mortality. In fact, there are probably at least 80,000 people right now with an undiagnosed cancer because they've missed their screen. So it's a tremendous problem, and the American Cancer Society is making this our top priority for our patient delivery programs for 2021, is attacking this from multiple angles to get people back to screening.
Thanks very much. As we look at screening, there's also the facet of surveillance, right? So you have the patients who've been screened and maybe we're picking up cancers late, and we'll come back to that. But then there's patients who should be coming back for surveillance as well, who've had their cancer treatment. Are we seeing a similar phenomenon for surveillance?
Yes, we sure are. And we don't have exact data for the surveillance. We've sort of looked at the screens as one, but clearly the surveillance is a critical issue and needs to be addressed as well.
Okay, so we don't have numbers on that one, but we have numbers for screening, as you said, perhaps 80,000 at the present time. So what are some of the initiatives? How do we get those patients to come in, number one? And number two, as patients start to come in, do we have data showing us that the disease is, as we'd feared, more advanced than it should have been?
So the multiple steps to get patients back in, it's going to take efforts across the spectrum. So first of all, we're convening a group of experts in the field, caregivers, get a scientific approach to how we can get people back. And we have people coming from multiple different organizations, cancer centers, and so forth. We need to work with individual health systems, which we have. We're planning to enhance efforts to talk to health systems about getting their backlogs done, have more slots opened up for screenings, working with the state coalitions, the cancer coalitions, and also working, we hope, with the Commission on Cancer and specifically the state cancer chairs, so we can make specific recommendations and have specific efforts in those areas. Also looked at messaging. What's the best message for individual groups of patients? And we've just completed a toolkit we've done extensive message testing by our communications experts to find out what messages resonate more in those groups. So then the question of data. We don't have good data yet on whether we're seeing cancers that are more advanced. There's certainly anecdotal reports, There's a few things that concern me with just the data of the, for example, the number of diagnoses. If you look at colorectal cancer diagnoses from a pathology standpoint in breast cancer, you see the drop in particularly March through June, and you see it come back, but it doesn't quite hit the 2019 baseline. And as Dr. Heidi Nelson pointed out, as you said, we're working about 120% to get 100% effort from a year ago. So that's first thing. But then the second thing is that we didn't overshoot to get those backlog screens and diagnoses. So they're still there. We're not quite back to baseline. So that really concerns me, that those diagnoses are there and certainly getting more advanced, but each day.
What are some of the specifics? You mentioned that the communications team has looked at specific messages that resound with specific people. And I think those surgeons listening and viewing today might want to know what are those messages that they could use them in their own practices too.
Sure. They vary. It's what type of messaging has resonated with each of the different groups. There's a number of depending on what groups of patients you tend to serve. So there's a variety of things that resonate more with one group than others. And actually, we're happy to share that. We will be sharing it with the Commission on Cancer, and we'd like to get it to every surgeon. So it's an easy toolkit that would describe in detail sort of what has resonated in each of those groups. So that's one of the areas of focus. The one area to mention is advocacy is also very important in this process. We really need advocacy. We have our Cancer Action Network actively working to try to get policies that won't penalize people for getting screens and encourage people for getting screens. And that's particularly important with the increasing uninsured population that we have in the wake of COVID.
Advocacy is certainly another common area with the American College of Surgeons, that we want to ensure access for our patients, and we want our patients to get what they need and not to avoid it for fear of it not being covered or reimbursed. That's a very important initiative. If I could just shift gears for a moment, are there any data on the outcomes of patients who were treated who were COVID positive? They had to be treated. And I know there's data in the some of the European literature, which is a voluntary registry, but I'm just wondering if we have any data in the US, people who couldn't wait for treatment but were COVID positive at the time of treatment.
The data that I'm most familiar with are the people who, the COVID patients in the midst of treatment, people who get COVID while they're in active therapy. It's primarily related to people on chemotherapy, and they have a much increased risk of adverse outcomes, up to even 5-fold in some series. I don't know of good data of the surgical, looking at patients undergoing surgery who get the COVID, who become diagnosed. So it's really been restricted to those people in sort of ongoing therapy and that's really with actively progressing cancers. Not as much data in those with neoadjuvant, or as I mentioned, in the surgery or in radiation.
Yeah. Although what we know from the data published from the COVID surge registry is that the mortality rate in that group of patients, and it's not all cancer patients, but many of the patients who had surgery did have cancer because the quote unquote non-essential surgeries were deferred, that the mortality rate was something in the order of 20% plus, which is vastly higher than it otherwise would be. Again, many of those data were in the early days of the first wave, I think, before people had a real idea of how to handle it. So that brings up, to go to the next area, given that it is potentially an increased morbidity, even mortality for medical or surgical treatment, is there any reluctance that you're aware of on the part of cancer patients to get vaccinated for fear that somehow it's going to have an adverse rather than a salutary effect on them?
Not that I am aware of. In fact, I am aware of the opposite, where cancer patients are having a hard time getting the vaccine. They really want to become vaccinated. They're in the midst of treatment. And I think there's a couple of points there. First of all, at a recent AACR conference with oncologists from around the world, they made the point that we're probably not doing enough to promote to push for vaccination in these patients. And there are very few therapies that would make you ineligible. You know, if you're on a B-cell therapy for B-cell leukemia, for example, or you're in a cell therapy, and those are very small numbers, those patients should probably wait. So there are very few cancer patients that shouldn't get vaccinated. So I think we really need to push for them to get vaccinated. They should be considered high risk, immunocompromised. The second area that has frustrated me has been the lack of use of the monoclonal antibody therapies. They were really off to a slow start. A lot of facilities have lots of them available, and they're a little difficult to infuse. You need an infusion center, but there are a lot of reports of people responding very well to those. So if you get them early in your symptoms, I believe they could really help, particularly for a patient in treatment who gets COVID. I think they're a underutilized avenue of therapy. And of course, we have to wait and see how with these variants, whether they will attack the variants. But for now, it's a really good alternative for treatment.
That's great. I'm encouraged to hear that patients are looking for rather than fearful of vaccine. That's fantastic. Before we close, I'd like to give you the opportunity to share any additional thoughts which you may in terms of the American Cancer Society relation with the American College of Surgeons or return to screening COVID-19. The floor is yours to wrap up.
Well, thank you, Dr. Wexner. First of all, I'm honored to be able to collaborate both with the American Cancer Society and the American College of Surgeons. I've been a member of the American College of Surgeons for a long time and have such tremendous respect for the organization and our efforts collaboratively that go back years and years and years. So working together, Commission on Cancer, and really in all the cancer programs, trying to find even more ways of synergy between our groups, I really look forward to. So I'm delighted to be here. Looking forward to getting us through and getting the COVID into the exit lane, which we all are, of course, and then trying to address particularly the screening, but really finding those people that have missed the screenings and getting the high risk symptomatic patients in as a priority as we move forward.
Well, I think on that note, it might be good if we conclude in a somewhat different than usual fashion, and let's show the audience one of those brief PSAs that the American Cancer Society has produced.
Great, and this is Dr. Laura Makaroff, who's our Senior Vice President for Prevention and Early Detection, who will finish our conversation.
Well, thank you, Dr. Kantz, and thank you for providing the video as well.
My pleasure. Thanks very much. Great to chat with you, Dr. Wexner, and look forward to more. Look forward to working with you closely as we move forward together.
Cancer doesn't wait. Neither should you. We know COVID-19 is top of mind right now, but remember to take care of yourself with routine cancer screenings. Talk with your doctor about when and how often to be screened, and make sure to ask about the steps they're taking to keep you safe during visits. Remember, cancer doesn't wait.
For more information, visit cdc.gov/cancer.